Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers Podcast. Excited to talk today with Lisa. Lisa is now a partner at Lumina or Lumina?
Principal, Lumina Health Partners.
Lumina Health Partners. But all that's fun. But at the end of the day, Lisa is really, really perfect for this podcast because Lisa personifies the intersection of care coordination and value-based care, which is obviously the central topic of this podcast. So Lisa, I'm excited to kind of dig into a bunch of your experiences. Thanks for joining today.
Yes, thanks for having me. And I think it was meant to be. We were connected in Washington, D.C. about 6 or 8 weeks ago and identified we have a shared love for care management. So thank you so much for having me, and really honored to be amongst all the folks that you've had on this podcast, really working to change healthcare.
So let's dig right into CCM. Okay, CCM is a huge program. Obviously, one of the primary programs that we do over at Proviva Health Group. You actually built a successful chronic care management program in-house for one of the large health systems. Let's talk about where you ended up, and then maybe let's go back to how you started and how you kind of built it.
Sure. When I left the organization, we were around 3,500 Medicare traditional and Medicare Advantage patients engaged in a chronic care management program. We started from zero. So one nurse launched the program with me in March of 2021, and we were able to work and grow that team into a staff of about 13 folks working remotely, taking care of a number of employed physicians for a hospital system that I was working with in the Chicago suburbs. So it was wildly successful, but lots of bumps and bruises and cuts along the way as we were learning how to utilize technology, engage the clinicians, the care teams, and really basically build the operations for this program as we were going along and working with the patients. So very exciting.
Yeah. And let's talk about from a patient care perspective, because I know that one of the really cool things that you did was not just build the program, but you actually tracked it and looked at kind of outcomes. What were some of the results of those studies that you did?
Sure. So lucky enough that I have worked in clinically integrated networks and integrated delivery networks for about the past 10 years, learning and working with ambulatory operations and primary care. So I have a vast knowledge of how primary care works, and then collaborating and partnering with those clinical operations teams. So we actually had access to the claims files from Medicare because we were in an enhanced track Medicare shared savings programs. So when we started to build those codes, the 99490, we were able to leverage our claims files and then look for that anchoring claim and then track the patient outcomes prior to chronic care management and post CCM. And we just, after about 2 years, started to see some amazing trends emerging in those populations and comparing those patients' outcomes to same PCP enrolled in chronic care management versus not enrolled, and major cost reduction in Part A and Part B because the patients were less in the hospital. So some of the trends we saw on the Part A side were the length of stay was down less than their peers. We had, shorter lengths of stay. We had, less hospitalizations. So those things really started to emerge. We noticed on the flip side, the patients were coming into the primary care setting on average 2 more times per year. And they were utilizing urgent care or those same day, urgent PCP codes versus the hospital visits. So we saw the pendulum really swinging away from ED and hospital back into the primary care setting. So it was really cool to watch that.
Yeah, which makes so much sense. Again, as someone that's doing this on the daily. I mean, it just makes sense from a common sense perspective. Like, you've got a team that are building relationships with patients, proactively reaching out to them. The patients know that if they call that care coordination CCM team, they have a much higher chance of actually getting through and getting helped. And so, I mean, the base question that I think this begs to ask is, why are so many patients ending up in the ER? And is it because they actually need to be there, or is it because of a lack of connection to their primary. And I think that the results that you've seen, and I think everyone on CCM that does it well, at least, sees, is that it could very well be the latter, you know?
Yeah, that's a really great point that you brought up. When I was developing the program, I spent a lot of time talking with the care managers. I would round with them on a regular basis. What are the patients saying? What are you finding are barriers? And I think, for those of us that have worked in healthcare on the clinical side, we think patients understand where to go. They actually don't. They're scared. They can't get through, and they've waited till the last minute. And now what they know is to either call 911 or go to the ER. We expect our patients to understand how to navigate our system, and it doesn't work. I've watched it in my own family. I've heard hundreds of stories from my care managers where the patients were saying things like, I didn't know you could help me with this. I didn't know that something was wrong with my pre-certification and I couldn't get my medication. They don't understand what those barriers are. And by being connected to a care team, they were able to block and tackle those things for them and navigate them to the right steps in the system. And that is where we really saw the cost reductions happening, is we were ushering them through the system. I wasn't leaving the patient to their own devices to have to make those decisions on their own. And that was really where we saw a lot of the impact financially.
You said something really interesting that kind of sparked something in my head. There's got to be data on this, and if not, we need to find it. There's got to be data of how many patients call 911. Basically, how many 911 calls are from patients that you just described. And here's why that's super interesting, because what you said is exactly mirrors perfectly something that I've been saying for the longest time, which is that, everyone in healthcare fights over who's supposed to be calling the patients. The payers try to call them, the doctor tries to call them, and the specialist tries to call them. And no one, I think very few people actually understand what you just said, which is, the patient doesn't understand healthcare. The patient's not thinking about, are you the specialist, or are you the primary, or are you the pay? All the patient cares about is being helped. That's all they care about. And so all they care about is who's going to pick up the phone and who's going to get me some help. And if I don't want to be on board for forever and I want to be helped, then the reason why I would think that there might be a lot of interesting data around that 911 scenario is because patients know that at the end of the day, if it comes down to it, 911 has a responsibility to pick up the phone, absolutely will pick up the phone, and has a responsibility to do something. Now, the problem is, all they have to do is call an ambulance, send it to the ER. That's what they have to do. They don't have, they don't care about necessarily the healthcare utilization. They care about, doing their job, which is making sure that people don't die, right? So that's really interesting. Do you have any idea if there's any data or any studies on that? If not, we have to do it.
No, we should go look about that and maybe have a follow-up discussion. But I'll maybe give some just examples for some of those chronic disease states that we know are really troubling to the system, right? Those top 5%, COPD, CHF. One of the things that we instituted in my previous organization was a readmission interview. What happened? Why is that patient back here? And we often found that the patients are so overwhelmed at the discharge, right? We're offering the kitchen sink, palliative care, hospice, home health, everything that we know that patient needs to survive and thrive on the other side of the four walls of the hospital, but they don't know when their wife or spouse is going to be able to take them to the next doctor's appointment. They're confused by why all these people need to be in their house, in their personal space, and it's overwhelming for them. So we found that with the care managers, let the patient discharge. Hopefully they'll take the services that are being offered, but if they don't, then my care team would pick that up and say, hi, it's, Edith from Dr. Smith's office. We want to have someone come check on you tomorrow. That was much more widely received. So I think it is just all of those things of, like we said, patients don't understand what is happening, and it's overwhelming. They're trying to process all the changes in their treatment plans, the medications they've been prescribed, and now all these new services that we're throwing at them that are maybe not all coordinated or owned underneath the same health system, right? Because we're building all of these community-based partnerships with our palliative teams and food banks and, areas where they can get adult diapers, and all the services are still disjointed. So where the care team really thrived was I wanted them to be the hub of the wheel. You connect, the system is the way it is. We can't fix that overnight. But what we can do is be that connector for the patient and pull all those services together for them. And CMS recognizes this challenge and is compensating providers for chronic care management. And so we were leveraging that reimbursement and that 20 minutes of care to say, what does that person need today, right? So today they might be in a car accident. Tomorrow their spouse might have died. All their needs longitudinally are changing as they live their life. And we're able to kind of be that conduit connected to them over years of time. And that really is what we saw drove the improvements in the cost mitigations.
Again, so perfectly said. And just 2 points there on your final point. I mean, I talk about how every part of healthcare is the most underappreciated part of healthcare, right? But the difference is that the underappreciation usually comes from outside of healthcare. I think that care coordination is the most underappreciated and undervalued part of healthcare from within healthcare. People just kind of knock it to the wayside. They don't really think about it much. It's like, yeah, it's just like low-level clinical staff doing some phone calls. But no, care coordination is the common thread between a patient's experience throughout healthcare. And like what you said about them coming home from the ER and being overwhelmed, that's like level 10 and that's 100% there. But it's even as simple as when they go to their doctor for their visits. I mean, I cannot tell you how many patients will come back from their doctor visit, pick up the phone, call their care coordinator and say, I don't know, I didn't understand a thing the doctor said. Can you look at the note and now explain to me in human language what's going on?
Right, because we talk at people and they don't understand these things, right? What's the statistic? 85% of what you tell them within 5 minutes of walking out of the office, they forget, right? And if many people go to the doctor themselves, they don't take someone with them. It's, you're dealing with elderly patients. Their cognition is potentially impacted. So even myself as a patient, you're going in and you're trying to absorb all of these things and you think, oh, what happened there? I don't remember why I'm even on this medication, for 3 years. So it impacts every patient, regardless if you're on Medicare or commercial. And people living with chronic conditions are trying to manage all these things, monitor their blood sugar, make sure they don't eat too much of something, take their medications every single day so that their sugars aren't elevated. And those are things that, I think those of us that are working to change the system, I think most of us have a family member or a personal experience that's really driven us into this type of work. And I would say that's the same for me. I want my family and my friends to have a better experience in the future. And that's why I commit my time and energy to doing these types of programs.
Yeah. Lisa, what were some of the barriers that you found from inside the system to actually building the program? Because the question is always like, no one will argue that care coordination and like CCM is a good thing. I mean, in the fee-for-service world, it's generating revenue. In the practical world, in the value world, it's actually bringing value. But at the end of the day, an extraordinarily small number of patients comparatively from Medicare, percentage-wise, are on a CCM program. Why?
There's a lot of support. Think about, I've been in primary care for a long time. The day-to-day compliance and operations and staffing and all those things, those team members are focused on delivering an excellent experience for that in-person, in-office interaction, right? Technology, the pandemic, things are outpacing the speed of what normal people can accept for change, right? And the promise of value-based care, right? It's a black box for some people. How do we get there? And so I felt like my role in that was to help listen. What are the challenges that you all are having? Look at the data, right? So data walks and talks. Where are our problems? I just so happened to be able to start the program like on the tail of, 2021 when we were all starting, trying to figure out how do we engage with our patients. So I think your environment is also key to being able to start something like this. But to be able to get over the hurdle, to get approval to hire staff from finance, I actually took the total cost of care. I used the Mathematica study and I found someone that could help me financially model what would this look like if we had 1,000, 2,000, 5,000 patients in CCM. What is the potential impact to our shared savings opportunity? P.S. I'm going to leverage the reimbursement from CMS. So I'm keeping the lights on, if that makes sense, for the staff, right? We're covering the cost of our resources that we're hiring, the labor, the technology vendor that we were utilizing. And then we were still generating a 20%, profit margin, which was the only profitable service line in primary care at the time. And then we were reinvesting that back into primary care, those additional dollars going back in. So the main hurdle to start was to even convince finance, why is this a good idea?
Yeah. Have you seen the new advanced primary care model?
I have, and I am just thrilled. I hope I get to help an organization with that one because, some of the other barriers, maybe on the consumer side, the consenting, the cost sharing, those are things we talked about when we were together at the Think 360 Value-Based Care Summit with some of the Senate and Congress staffers. We really need your help there. These should not be barriers for patients to join these programs. We know with even the little data that we do have, like you said, 4% of NPIs in the country are utilizing CCM. There's enough data there to know that these programs generate positive ROI for both the patient and the healthcare system as a whole. So getting rid of patient cost sharing, the great thing about APCM is the time. Now, we had to structure the reduction in time.
Are they getting rid of the copay for APCM?
No, they're not getting rid of the copay, but there's no time requirement, which I think that part.
No time. I was like, that would be.
Oh, it would be. That was what I'm advocating for is help get rid of the patient cost sharing. That's a barrier, right? Because patients are concerned.
It's not just a barrier. It is the barrier. 80% of patients that would be on a CCM program are not on the program because of the $8 to $16 a month.
It is.
End of story. It is crazy.
End of story. And then what ends up happening is if you find a patient that's in a financial needs situation and you follow the Medicare guidelines about being able to waive any type of patient cost sharing, now the physician's being impacted, right? The system, the care teams are being impacted financially. We're still doing the service and then we're not recuperating what we should be recuperating. So patient cost sharing is definitely a barrier, but APCM, the hope for that, I think is just extremely exciting. And CMS, I think, is really listening to, the value-based care advocacy teams, as well as any provider advocacy teams, because I might only need to help this patient for 7 minutes. And I don't want to intentionally drive unnecessary utilization, right? That's what we're all trying to get away from. Yeah. But the way CCM was set up is you were only able to bill if you were delivering on that 20 minutes. So right. Very exciting. And the new code for one chronic condition, right? Being able to help all comers in Medicare, I think, is very exciting.
What is it? PCM for the one chronic condition now. But I think that the main thing is getting rid of the time requirements. I mean, it's so exciting because it's really the next step of converting CCM further into value-based care. At the end of the day, I was sitting with someone from CMMI, and I remember like kind of laughing with them, like, who in your boardroom, like at the meeting, raised their hand and was like, I have the magical number of minutes. It is 20 minutes cures all ailment. With that. And so getting rid of that. Now, my only question is the only thing that I really want to explore further is that the APCM model has the opportunity to either completely eliminate fraud or increase fraud tremendously. And it's all going to depend on what they're actually auditing and what they're actually kind of holding you accountable for, right? So one of the positives of time-based is that it's a very easy kind of accounting metric where you're like, you got to keep time, you got to keep time logs. If I see, it's also easy to kind of detect fraud because if I see that you're just marking off 20 minutes, or worse are the people that mark off 20 minutes and 19 seconds, but for every single patient, that's pretty easily awful. And like, okay, you're probably doing something wrong here. But on the flip side, it's an unintelligent determinant for success. With APCM, if it really depends on what they're going to be auditing. Like, what are you going to consider to be quality? What are you going to consider to be moving those metrics in a positive direction? Like, what does that actually mean for real? is a question that I still have. I don't know if you have any clarity on that.
I would agree with you. I think those are difficult, and you hope that bad actors are the lesser of the situation than the ones that are really trying to make those changes. I would say even within the 20-minute metric, one of the things that my clinical leaders came up with, which I think was just brilliant, was we lived and breathed on the care plan. And what I mean by that is we were able to audit, okay, we created this care plan in January of 2024. By April of 2024, that thing needs to be touched again. Now, if you look at the CMS criteria, that's not actually a requirement. It's one-time care plan that it's documented in the chart. We didn't think that was enough. We wanted to be able to demonstrate that we were doing the right thing with the resources that CMS was giving us. And so every 90 days, nursing teams, additional care navigators were looking at that care plan, reviewing the goals. Is the patient moving toward the goal or not? And if they're not, then we need to figure out what the goal is or what the barrier is and reassess those. Every 100% of our care plans were monitored every 90 days. And every 6 months, patients were screening for social determinants of health. So every 6 months, we're checking in. Can you still afford your food? Do you still live in a safe environment? Can you still afford your medications? That created, a pool of identification of social determinants that we were now notifying our physicians. By the way, Mr. Smith screened positive for food or financial insecurity. Here's a potential diagnosis code you may want to consider the next time he comes in. And the doctor started to ask me, Lisa, why are you telling me this? And this was, before the health equity indexing and things like that. I saw these things coming from CMS. If you are in risk-bearing contracts, social, determinants are going to start risk adjusting. They're not there yet, but they're coming, right? So being able to get the infrastructure in place and the operations for the clinical teams, well, now that we're identifying them, we can actually address them through CCM, where I think a lot of clinicians were really frustrated over the years. Well, we know this patient can't afford a scale or, is going through the drive-through of McDonald's every day, but we don't have time to do anything about it. And now we were giving them a vehicle to address those changes. So I would say if CMS would do anything is look at organizations that are really proactively leveraging that care plan and that is actually updated in the charts and it's being worked on a regular basis and the goals are there. So that's what we did.
I like that a lot. I think that's a really good first step. The things that I'm thinking through are, it really just comes back to like just first principles and common sense around it, really, is how you have to kind of think about it, which is so difficult to do in healthcare because you're starting from within a box that's within a box that's within a box. It's like so this completely alternate reality. But I mean, practically speaking, there's goals that are going to be too big. If you make the goals too big, then you're not going to see a lot of progress on it, right? If you make the goals too small, then they might not be meaningful. So you got to find kind of a balance on what the goals are. And then, but I guess you can fix that with just like from the clinician side. Like the clinician should know the patient and they should know what's doable and what a real clinical goal is and not just trying to list paper, right? Interesting.
So we use SMART goals, right? Just like you use SMART goals when you're working at home.
Yeah.
I'm a big proponent of behavioral science. One of the main reasons I started this program was sort of my own challenges with obesity and hypertension and understanding what it actually takes to change your life and the daily support that's needed to do that. So if you are taking a diabetic who's drinking 12 Cokes and eating, a pack of tortillas every day, you're not going to rip that out from underneath them. It's okay. We need to start to work on making small changes every single day, because I think where most people get lost is I'm working out. I'm going to eat totally clean. I'm going to drink water all day. And you try to give yourself 10 things and you can't do it.
Yeah.
Sometimes it's a 6-month conversation with them about what can I get you to start doing? So there's all of those things that we would work through with the patients. We can't get you out riding a bike, but you can do chair exercises. And actually, here's some links. Here's some YouTube videos. Here's some things from CDC, really trusted resources that we would give the patient to work on. And then we would check on them. Did you open the video? Did you use it? Because you're connected to them and you can check every few days, how are they progressing towards those goals that we gave them? So we saw success there of giving them more of a bite-sized goal and then keeping that care plan moving every 90 days, allow the patients to really, latch into what they needed to do to make those changes. So.
Yeah. Man. Well, let's talk about what you're doing now. What's Lumina Health Partners? What are they?
Yeah, so Lumina is a national healthcare consulting firm focused on value-based care, expanding into some care management strategies, financial contracting, things like that. So there's the wide variety, a spectrum of value-based care. And I'm hoping to work with organizations and bring my learnings forward on chronic care management, some of the challenges that we had, and accelerate organizations' adoption of CCM, even on a small scale, being able to help support primary care and cardiology specialist offices and building these types of programs will continue to expand care navigation across the country. So that's where I'm at these days, looking at supporting some organizations on delivering on the CCM and primary care, APCM models, and principal care management for the specialists.
Now, any thoughts on 2025, new, very, very new healthcare administration coming in? Any thoughts on kind of where you think that'll go?
I think we're going to continue to see an expansion of Medicare Advantage. What and how that feels for the consumer, I'm not sure. I just know personally, people are really going through sticker shock right now, seeing those Medicare premiums coming for 2025. And this is going to continue to squeeze patients. And I think getting them into Medicare Advantage, whether or not that's good or bad, I don't know. I think it's sort of a optimistic, but wait and see what happens. Yeah. I do believe that we will have more access to things like you and I are talking about, the care navigation, food as medicine. I think we'll be taking some center stage there. Those are all really exciting because those are the things that patients really need to actually change the trajectory of their health. And keeping an eye on the guide model, interested to see what they are able to pull together in the dementia space, and all at the end of the day, it's all care coordination. So how you fund it, how you operationalize it, what environment are you living in, right? You need to know, are you mostly fee for service? Are you global risk? The program themselves is, maybe structured financially a little bit differently, but they all will get you the same result for your patients. So excited to see where that goes, but still a little unknown for me, I think, in 2025.
Yeah, I think I feel exactly the same. I've been saying this very similarly. I think that value-based care is going to be something double down on. I think that the idea of shared savings and using the power of shared savings to, to push down, cost. I think that care coordination is going to be a really central part. So I'm pretty optimistic as well, but same big question marks. Again, when the rubber hits the road, how that's going to look and what it's going to do. They're talking about, are they going to get rid of the whole CPT code handbook and moving? There's a lot of big.
I saw that. There's
conspiracy theories, or I don't know, theories being floated. So it'll definitely be interesting. But I agree. I think it'll be positive.
Yeah, and one other thing, you talked about shared savings. I know this has been a challenge. I've been doing Medicare shared savings programs for over a decade. You try to get clinicians and healthcare organizations to make the changes. They want to make these changes, but the funding's not there. You're going to earn your money maybe 2 years later, right? CMS has made some changes for low revenue ACOs to start getting some of that, cost sharing in advance. And so I think that's really a huge step to help, groups build the operations that are necessary. Some of these things, they take a year or 2 or 3 to actually see what results are going to generate. People don't change overnight. So shifting operations is like moving a Titanic. It doesn't go fast. So we do need the infrastructure in order to do that. We can if we're financially supported in order to do so. So exciting things there coming from CMS.
Awesome. Well, Lisa, always fun to talk to you. Continued success at Lumina Health Partners, and really, really excited to keep in touch as we move into 2025 and see how things pan out. I think hopefully in a positive direction.
Yes, and honestly, congratulations on the announcement with Careco. As people were commenting, you assembled the Avengers team. I thought that was a really great way to personify what's going on there. And thanks to you, because as CMS continues to evolve these models and time may not be an issue, being able to leverage technology like Careco is going to be critical for care managers to alleviate some of those monotonous tasks or digging through 50 pages of medical records to find information. So really excited to see what you put out there, and keep an eye on your organization as it grows and evolves. So hopefully we'll be working together someday.
Absolutely. Lisa, thank you so much. This was really fun. And till next time. Thank you.
Yes. Thanks, Mendel. Have a great day.